All right, well, I guess I'll go ahead and get started. I think it's basically 10:30. My name is Morgan Bercoli. I am faculty at Brigham and Women's, and thank you all for coming to a Friday afternoon, or I guess late morning talk. I am here on behalf of the Global Emergency Medicine Literature Review team to present the top global EM articles of 2023. I have no disclosures to report. So if you aren't familiar, the Global Emergency Medicine Literature Review is in its 18th year of publication in academic emergency medicine. As part of the review, our mission is to highlight and disseminate high-quality global EM research, to illustrate best practices, to stimulate additional research, and to promote further professionalization of global EM. We are not a systematic review or a meta-analysis, but we do have a rigorous structure and a standardized approach to the review. Our initial review begins in PubMed with a keyword search in several languages, and it highlights important terms in both global emergency medicine as well as global public health terms. And this is so we can cast a wide net to find the best articles. We perform the search twice throughout the year. The first one covers articles published through August, and then we do an additional search to cover articles published through December. We also do a separate hand search of some of the key journals, journals most likely to have relevant articles, just to make sure that all appropriate articles are included. And these are some of the journals that we perform a separate hand search in. Once the initial search is performed, we generally get, I'll show you later, but tens of thousands of articles. Those are all then screened for their relevance to global emergency medicine. Specifically, all articles selected at this stage must fall into one of these three categories: either emergency care in resource-limited settings, disaster and humanitarian response, or emergency medicine development. These articles are then categorized as either original research or review articles, and the original research articles are designated as either quantitative or qualitative methodology. After screening, we end up with several hundred articles that are then scored. These are all scored by two different reviewers. We have standardized scoring rubrics for different types of articles, and they consider the article's clarity, study design, ethics, importance to the field of global emergency medicine, and likely impact on global EM practices. After we score all of the articles, the top scoring articles are then summarized and given a full review by the members of the GEMLR team. In addition to the main review, we perform a separate search through the gray literature. And these are articles published not in index journals, but through less formal communications, including news bulletins, practice guidelines, other media. As part of the gray literature search, we search the websites of these organizations to make sure we're capturing all of the relevant global EM literature. As you can imagine, this is an enormous effort, and it requires a large team. We are also proud to, well, we try to be as representative as possible, and this year we have 9 countries represented on our review team. So the main part of this presentation is to show you the top articles that we found in 2023. This year, our search yielded just under 45,000 articles. This was approximately 15,000 articles fewer than the previous year because we modified the search string a little bit to make it more specific. We selected 890 articles for for scoring. And after scoring those 890 articles, we now have a list of the top scoring articles from 2023. I can't tell you how many are going to be included in the final summary because we actually haven't gotten there yet. But most years, it's around 30 to 35 articles. Our top scoring original quantitative research article this year comes from Garg et al. In the Journal of Global Health and is titled Cost of Treating Sick Young Infants with Possible Serious Bacterial Infection in Resource-Constrained Outpatient Primary Care Facilities, an Insight from Implementation Research in 2 districts of Haryana and Uttar Pradesh. So as a background, the neonatal mortality in India is quite high. And the incidence of neonatal sepsis in India is actually the highest in the world. And neonatal sepsis is the second leading cause of neonatal mortality in India. WHO guidelines recommend that infants with either sepsis, referred to as possible serious bacterial infection or PSBI, are referred to hospital for further management in the 0 to 59-day-old cohort. However, in resource-limited settings, specifically in India, they found that many families of young infants with signs of PSBI don't accept a referral to the hospital for various reasons. This can be due to distance, cost concerns, missing work, other children, et cetera. However, there have been RCTs that have demonstrated that antibiotic regimens for young infants with PSBI in the outpatient setting are effective. So in India, they implemented WHO's IMNCI protocols aimed at increasing access to outpatient treatment for infants with PSBI or pneumonia. They also found that data about the cost of treatment for these neonatal infections in the outpatient setting are limited. So to do this study, they calculated the cost of treating infants with PSBI or pneumonia in 2 districts of India. They calculated both direct activity costs, which included staff time, consumables, the actual treatment itself. So for pneumonia, that's oral amoxicillin for 7 days. And for PSBI, it's IM gentamicin and oral amoxicillin for 7 days, and daily assessments. They also calculated indirect operational costs, which included staff training, staff time costs for things that were not directly related to patient care, such as management, supervision of the clinic, coordination, any transport needs, and communication. I don't expect you to see this, but this is one of the tables from their paper that just shows the costs in US dollars for each component of the care for these infants. And what they found was that the direct cost of outpatient treatment was quite low. It was between 60 and 90 cents for pneumonia and between $6 and $6.50 for PSBI. The average total cost for pneumonia treatment was US $10, and then the average total cost for PSBI treatment was US $16, and this is per infant. An interesting part of their findings was that 30% of these total costs came from the pre-outpatient treatment category. So what they did was, in order to find these infants, they both trained new mothers in the signs of neonatal illness, as well as they went around and did home visits for all newborn infants. So that took a significant amount of money to do these home visits to find the infants who had pneumonia or PSBI. So in conclusion, they found that outpatient management for PSBI is cost-effective using a combination of IM gentamicin and oral amoxicillin. Again, when referral is not feasible, right? Like the recommendation is to have these infants go to hospital. And also for pneumonia, and that was only oral amoxicillin. The cost of treatment of PSBI with the recommended regimen was under $20 per child. It was close to $16. And that they were able to, or it's important to successfully identify and mobilize infants with PSBI, and they achieved this with postnatal home visits and education of mothers. So our next article is the top scoring original qualitative research article, and this is from Ononge et al. In Global Health, Science and Practice, and it's titled Strengthening Kampala's Urban Referral System for Maternal and Newborn Care through Establishment of an Emergency Call and Dispatch Center. So as background, most pregnant women who are living in urban slums in Uganda deliver at public health centers that are not equipped to provide emergency obstetric and newborn care, known as EMONC. And we know that 50% of obstetric maternal deaths could be averted through the provision of emergency obstetric care. When obstetric emergencies occur in these settings, the pregnant women are referred to a higher level facility, but they are responsible for arranging and paying for their own transport. So this study group, the Kampala Slum Maternal Newborn, they call themselves, I don't know if it's MANE or Maine, but they developed an emergency call and ambulance dispatch center, as well as a mobile phone application, so that patients could request and then they could deploy and track ambulances. This was a mixed method feasibility study, which assessed the acceptability and demand of the interventions using interviews with stakeholders, as well as quantitative data from call center dispatch logs. So one of the things I found most interesting about this study is you can see the study period is from April 2020 to June 2021. And we know that, I'm sure a lot of us have had experience with maybe planning studies that happen to go live at the same time as COVID happened, not intentionally. So the Emergency Call and Dispatch Center was established specifically for maternal and neonatal health requests. However, because this went live at the beginning of COVID, they did not restrict the service to the maternal and neonatal health calls. They actually opened it up to all calls and all requests. So during this time, just over 10,000 calls were made, and 28.7% of those were related to maternal and newborn health emergencies, but that's over 70% that weren't related to maternal and newborn health emergencies. Just over 14% were COVID-19 related. And you can't see this, but one of the tables in their paper on the right shows the different types of calls. So the call categories were maternal health related, newborn health related, calls related to child illness, calls related to other emergencies like medical and surgical emergencies, trauma, and then also a lot of calls related to just general health inquiries. I think they had a lot of inquiries about COVID in general, transport needs, et cetera. An ambulance was dispatched to transfer patients in 35% of these calls, but an ambulance was dispatched in 84% of the maternal and newborn health calls, which was the primary aim of their study in the first place. So also what I found interesting was the majority of their calls, so 60% of their calls during this study period were recorded during the first 2 months of the establishment of this call center. That actually corresponded with Kampala's first COVID-19 total lockdown. So during that time, movement was restricted and only essential workers could go out and leave their homes. So they hypothesized that a lot of the call volume during that time was because people were in lockdown and they didn't feel like they had any other means of getting around. This graph The orange line shows the percentage of calls that were related to maternal and newborn health. So in the early phases, you can see that the orange line is, like, the percentage is quite low. And then later on, when you get to December 2020, it's 80 to 90% of the calls are maternal and newborn health calls. And then, maybe I have, over here, it drops off again. They hypothesized June 2021 was the second COVID lockdown in Kampala. So they hypothesized that, again, they were getting a lot more non-MNH calls during the lockdown periods. So the results of their qualitative study, participants acknowledged that the call center and mobile application allowed for efficient communication, coordination, and information flow between health facilities. They found that the call center was able to accommodate the COVID-19 pressures, and they concluded that their intervention was flexible. And I think, to me, the most interesting is they wrote that in resource-limited settings, having a referral system for only maternal and neonatal health services might not be cost-effective. And they also found that they had very supportive district leadership that supported the establishment of the call center, and they have since taken over the operating costs, so this is now all internally run. And as a conclusion, they said that this model could be scaled to address referrals for all types of emergencies, not strictly maternal and neonatal health. Our next paper is the top scoring the top scoring review article, which is a systematic review. It comes from Doc Ponu et al. In the Journal of Clinical Neuroscience, titled Transcranial Doppler in the Non-Invasive Estimation of Intracranial Pressure in Traumatic Brain Injury Compared to Other Non-Invasive Methods in Lower Middle Income Countries, Systematic Review and Meta-Analysis. So as an overview, as we know, management of patients with TBI requires intracranial pressure monitoring to prevent secondary brain injury. The clinical standard for ICP monitoring is invasive. However, having a reliable, non-invasive method would be preferred, especially in lower middle income countries where the resources might not be there for invasive ICP monitoring. So this group did a systematic search of several databases, and they were specifically looking for studies that reported the prediction of raised ICP in TBI patients by non-invasive means in LMICs. This is their PRISMA diagram. Ultimately, they selected and extracted data from 15 studies for a total of 3,316 patients. This is one of their tables about the patients that were included in their included studies. And I included this table just to show the modalities of ICP monitoring that these studies represented. These modalities are transcranial Doppler, CT scan to measure optic nerve sheath, ultrasound of ICP, arterial blood pressure, and MRI to measure optic nerve sheath. And what they found was that ICP measured by transcranial Doppler had a sensitivity of 92.3% and a specificity of 70%. And this was the most accurate modality that they found with their systematic review. So their conclusion was that out of the 5 non-invasive methods for measuring ICP in patients with TBI, the transcranial Doppler was the most accurate. And this has implications for low and middle income countries where invasive methods might not be feasible. However, they did point out that none of these studies were RCTs. They were mostly case reports or case series. And so we need more robust evidence to support using transcranial Doppler for this indication. And I'm almost at time, but just quickly, our total articles screened for the Gray Literature Review this year was 11,000. Of those 11,000 articles, 37 were selected for scoring. And the top scoring article this year was "No one came to our rescue," which is a descriptive report from MSF. And this descriptive report looks at EU migrants in the central Mediterranean. They did anonymous interviews with survivors who were rescued at sea on one of their MSF vessels. And these interviews highlighted many traumatic experiences that the migrants faced, both in their origin countries as well as on their migration path to the EU, including injury, gender-based violence, unwanted pregnancy, witnessing rape, murder, and torture. They listed many political challenges that are faced by NGOs who are caring for these patients, as well as migrants at sea. One of them that we're highlighting is that many of the EU countries have legal agreements with other countries to accept migrants who are, to take migrants back, essentially. And many of these accepting non-EU countries who are taking the migrants that are trying to reach the EU themselves have known human rights violations and are not safe destinations for these migrants who are fleeing violence and persecution at home. One of the examples they gave is Libya accepts migrants who are fleeing to Italy and are turned back. All right, so on behalf of all of the GEMLR team, thank you for your attention and coming here again late on Friday. If you know someone who might be interested in being part of our team and contributing to the review, please consider applying. I believe the applications go live this summer, but this is the contact information. Thank you. Any questions? With the caveat that I did not do any of these studies myself, so